strategies for current weight gain.
Yeah, thank you very much. I'm honored to be here. This very impressive event. To come again, thank you very much, Sanjay. Thank you, Jessica, for opening up the topic of weight gain. If I have my presentation, that would be nice. Should I press something? Yes, gain, not regain, because it's exceptionally getting to the initial weight after the bariatric surgery in the patients, including sleep. Should I do something? It will come. So how many of you are performing as a main option sleep in this room? So it seems 35%. Okay, so that's, I imagine that the rest are performing the main procedure bypass. So let's see for the sleeve what we can do. Nothing to disclose. So that as the first option is the sleeve, so if there is weight gain, we need to be prepared to do something. And it has been chosen for many programs because we know that the results are comparative and with some other options from the metabolic point of view, but fewer complications. Now, of course, weight gain is coming after any bariatric procedure. And in this study, it is shown and expected then that at least more than 10% will be regained 10 years after. And it is multifactorial. Jessica underlined very well what's happening after in the circle of blame. Thank you, blame. I will focus a little bit on the surgical options that we do have. Now, it seems that after sleeve, there is a need to revise the surgery at 10 years in about 10% of the cases. And blindly, it is in this review showed that the most of the revisions are to Roux-en-Y gastric bypass. At least this is the evidence showing. And not following what it should be a strategy in what we should do with those patients based on the individuals, the multifactorial causes of weight regain. And if there will be a need for any revise, we should focus to the primary sleeve and understand if there is something to correct in there. And when was the weight regain, because it will make a difference if the weight regain came the first year after the surgery or 10 years after the surgery, why you should revise, either for reflux or weight regain, and then to think about which type of procedure to go for. That can be not blindly a Roux-en-Y gastric bypass. So sleeve got many options. It has been discussed here. You can preserve the sleeve construction, or you change the sleeve construction to a Roux-en-Y or a OEGB, but there are more options if you keep it, except the balloons that has been discussed this morning, and adding the anti-obesity medication, including the magnets and everything that has been discussed in Sleeve Plus. Roux-en-Y was the first option, and it looked logically just to cut the stomach and connect the small bowel, but the results were not that were expected. And this is a study showing that the patients that were revised either for weight regain or reflux or combined, 3 years after they returned to the initial level after the sleeve in the worst position. And if the reason was only the weight regain, was even worse. So Roux-en-Y seems that it's not working. But the OEGB, this is the same result for this study coming from India, the same level after 3 years. In a comparison of OEGB and Roux-en-Y, a high quality study, comparative study, it showed that 3 years we are reaching the same level, no matter if we do for OHB or Roux-en-Y gastric bypass, with more nutritional imbalances for OHB as expected. We can bend, yes we do, but there are only few cases and more complications. It's very attractive to do application either laparoscopically or endoscopically, but few studies and not that impressive impact. But for the dilated stomach that we need to look for, if it is the case, the re-sleeve, it should work. This is something that you should not see at the study, a dilated stomach. This is a study from France, and it seems that 20 months after the result is pretty good. This is another study 2 years after the results are pretty good after sleeve, because now sleeve is acting in these very cases. And this is our study. Now we have 5-year studies that are showing that after offering the procedure to those very patients that should be studied, what the results are good at 3 years and 5 years after. In comparison, more procedures, if searched from the study, the Roux-en-Y seems to be inferior than re-sleeve. The best is OHB here. But be aware, because too much hypoabsorption, it is going to some other issues that we don't want to see in these patients related to. And they are not going to come to check as a follow-up as we imagine they are going to merit with the hospital. No, they will not, and the imbalances will come over. We can keep the sleeve construction and add the PPD in study. Again, the malnutrition can be the issue. We can do all kinds of combinations that were nicely presented here by Rui, but we cannot guide the foot going to the right or to the left. They will avoid the pylorus, and the mostly flow will be toward the ileum, and we will have, instead of the advantages that are written here for the primary procedure, a lot of disadvantages and pitfalls for these patients. However, the revision to study of a sleeve, it is not that often present in the literature. This is one of the studies, and the risk of malnutrition is mentioned there. Magnets can be a good option because they are connecting the duodenum, so post-pyloric connection with the ileum, and it seems that it's much better for a primary operation than a revisional one. So in the area of anti-obesity medication, probably we should think about what can be added to a sleeve that worked at some point, and now we need some upgrade. And there are many studies. I will not insist, probably we will discuss these days more as well. But remember, we have many options for these patients. We need to carefully judge. There is no one size fitting all. We need to study, and wherever there is a dilated stomach, we need to act surgically. And this is the strategy. Keep the sleeve and do a re-sleeve and anti-obesity medication for a dilated stomach. Think about the smokers, the chronic medication patients. Keep the sleeve and intestinal bypass whenever it is. If there is no dilated stomach, and we have a compliant patient and type 2 diabetes came back, and change the sleeve construction for reflux or some issues with the stomach. Always look for the heart hernia and fix it. Thank you very much. These are the conclusions. We expect some weight regain. We should judge every single patient, but there are a minority for these patients. And with this, we would like to see you all in Venice next year, where the European chapter of LIBSS2024 is organizing our event. Thank you so much.